going to the preschool or the daycare to observe the child in that setting. And then lastly, it's very critical in this age period to make sure that the appropriate cognitive, social development, and motor development measures have been done, because in most states, children from 0 to 5 have access to services for developmental delays. And about 40% of preschoolers with a psychiatric disorder will have a language delay of some kind, and many of them have other delays. So you don't want to miss something that can really be helped with services that are available for the child. Now, this is the point that you have to assess across multiple domains. It's not enough just to do the psychiatric symptoms. And I made the point about making sure there aren't other developmental disorders. You have to make sure there aren't medical disorders going on. But a critical key aspect of the infant preschool perspective, which frankly I think is relevant across the lifespan, but it's absolutely critical in very young children, is you cannot assess the child in isolation from the family. So a complete psychiatric assessment of a young child is going to involve understanding parent psychiatric disorders and substance abuse, the parent-child relationship, how the family is functioning, what the neighborhood and the environment the child is living in, and the child's socioeconomic situation. Now, as we develop more and more measures, these will be available for clinicians. But from my perspective, it's very important to have some measures that are providing some kind of baseline of the child and the family's symptoms and functioning. That's important for defining what's going on, but it's going to be absolutely critical for following treatment and deciding whether or not the treatment you're doing is successful or not. Now, this is absolutely critical in this area because there's such a dearth of treatment literature, either in psychosocial realms or in pharmacological realms. So you have to be really clear about what the symptoms you are targeting are and whether or not you're seeing a change in your treatment, because if you're not, you need to try something else. This is just a review of different parent report measures that are available for people. I'll just leave it up for a moment so that people can record that. They're measures that address the child's symptoms, measures that address the parental psychopathology, but also their stress as parents and their functioning as parents. In my clinic, I have both parents fill out these measures because I learn a lot about the different ways, the different experiences the parents are having, but also the different ways they're seeing this child and they're seeing the child's symptoms. Now, clinically significant anxiety in young children. I went through the research data, but these are 5 points that I think are important to keep in mind when you're trying to make a decision whether or not this is normal anxiety or whether it's clinically significant. First of all, it's got to be causing the child distress in some way or avoidance. And so you may have a child who gets completely freaked out when the mother leaves, so the parents don't send the child to preschool and never go out and leave the child with a babysitter. So the child's not distressed, but the entire family has moved itself around to avoid having the child get so upset. The other thing is the symptoms have to be pervasive. They can't just happen when the child is tired and going to bed, or when they're going to a new school and it's the first week. It has to be pervasive across settings and also across relationships, because if things are just happening with one person, then you have to be a little bit concerned about whether or not there's a disturbance in that relationship between the child and the parent. The anxiety has to be uncontrollable to a degree. So if you have a child who gets upset and you say, I know you don't like it when mommy goes out, but we have to go out to dinner now and we'll be back, and the child pulls himself together, that's different than a child who tantrums for an hour and just gets completely hysterical. The symptoms must be persistent. So again, they can't just occur and then go away. And lastly, they have to be impairing the child or the family's functioning. One point that we really stress with young children is you have to look at how the child's symptoms are impairing the whole family, not just the child. Because as I mentioned, particularly with anxiety disorders, families may make routines to avoid having the child get distressed. So the child thinks that's fine. Their functioning isn't impaired, but the entire family is unable to function in a way that works for them. Here is looking at, just to say that you have to look at different domains, medical domains with young children. You can't just focus on the psychiatric. So you have to take a full medication history. That's particularly true in relation to PANDAS. And then the domains that are important involve the parental and family history of anxiety. And I wanted to make the point about risk factors. Domestic violence is very important to get at, as well as that include between parent and partner and the parent and child. And also you want to understand the adverse and traumatic life events. So lastly here, I'm going to give you an overview of the treatment literature and recommendations of use of medication with very young kids. Now, what you'll see in presenting is there's very little data. So there are no placebo-controlled studies of any kind of psychosocial intervention with young kids. There is some evidence from clinical experience that many of the cognitive behavioral approaches that are used with older children can be effective with the young children. And so people can try to down-age those. The key point is you never do behavioral or cognitive behavioral therapy alone with the child. It's always something that you do with the parent and the child, and particularly recruit the parent to be in the role of sort of a coach. And so you can do it together, and so they can practice the different techniques at home. It's strongly advised that you do some kind of psychosocial intervention before you try any kind of treatment with a medication. Now, there is some evidence for treating anxiety disorders in older children with medication. So there have been positive results, particularly around use of SSRIs to treat anxiety. There also have been negative studies for a number of things, mostly the benzodiazepines, imipramine, which is a tricyclic antidepressant, and buspirone for treating anxiety in older kids. There are no randomized controlled trials in young children to treat early onset anxiety disorder, and this is only to show you the absolute paucity of the literature, that it's basically 3 case reports and an open trial with 7 children. So I'm showing that to you to say, in rare cases, and you see I've put rare in bold letters, you might consider medication. Now, I run a preschool anxiety clinic at Duke, and I can count on one hand the number of times I've used medication with young children. So it is not something that you want to do without having tried very much to do any other kind of psychosocial intervention. The cases where you might think about it, you want to make sure you have the right diagnosis, or the child is so impaired that they can't benefit from any other kind of psychosocial intervention, or basically that the situation is so severe that the child might have to be removed from the home in some kind of way. So your first choice, if you were going to do this, would be fluoxetine. Again, you want to use very, very low doses and go very slowly. The key thing with any kind of medication with young children is have planned into the treatment, one, a discontinuation trial. So if you think it's working, you have evidence it's working, you want to stop it and show that the symptoms come back, and then only have the child on it for any length of time once you've been convinced of it. The other thing is that even if you are convinced this is helpful, you've done a cessation trial, after the child has been on this medication for 6 to 9 months, you should stop it to make sure that the child still needs it and the symptoms are coming back. In very rare cases, you might think about fluvoxamine, but I would recommend a consultation with an infant or preschool psychiatrist if you were going to do that. The other thing is switch. Do not add medication. You should not be putting a child of this age on more than one medication. These are the medications that are not endorsed for use with preschoolers. That includes benzodiazepines, except if the child has to have a medical or dental procedure and is so anxious that it can't be done. Alpha agonists, TCAs, or paroxetine. So those are not recommended for use with young children with anxiety disorders. So my final thoughts in terms of medication is